that's a little better then. Good. See a lot of patients. I speak for a lot of different pharmaceutical countries. I go around the country doing that. I've been at symposiums. I've had the opportunity to work with a lot of patients with Parkinson's disease in all of my different units. I spend time going around the state to work with patients with intellectual disabilities. I go to, oh my goodness, 20 or 30 different homes. I go to nursing homes. I go to residential care facilities. I see a lot of patients, a lot of very sick patients. We're going to talk about mental health issues in Parkinson's disease. And we will get to psychosis of Parkinson's disease, for which we have a very good medication. But let's start a little bit with some of the mental health issues. And I think we can begin with probably one of the earliest things we see in Parkinson's disease is apathy, just not caring. It's a little different from depression, but there's a tendency, as there is with some psychomotor slowing, to have this sense of apathy, this lack of real motivation, this lack of wanting to get up and about. Come on in, we got plenty of room here. So apathy is early. Different from depression in the sense that depression has this tendency to have a sadness about it, associated with being withdrawn, not wanting to be with others. There can be this just no joy about life. There's a sense of just not wanting to go on. I just kind of hopeless feeling, sometimes a helpless feeling. The depression is something we want to treat early. And we know that when we get treatments for depression early in the course of the disorder, this can make a big difference in brain function. And as the brain improves in terms of cognition, so does function. There's more ability to want to get up and move around. So depression, how do we treat that in Parkinson's disease? Maybe a little differently. Not that differently than we would in someone that didn't have Parkinson's disease. The standard care of depression are the medicines you're all familiar with, the Prozacs, Paxils, Zoloft, Selexis, Lexapros. They work on serotonin, and serotonin is the feel-good chemical. It's a chemical that makes you feel happier. So when serotonin levels drop, you feel sadder. And those medicines like Prozac and Lexapro and Zoloft, they tend to have one main mechanism, and that's put more serotonin in that synapse between the cells. So with that, we frequently see some improvement. But since we've had the development of other medications, we see even more improvement when we go to those. Next, if you've already been on what we call an SSRI, probably the one medicine that is maybe not used enough in Parkinson's disease for depression is one called Wellbutrin. It's called bupropion. That works on the norepinephrine and dopamine system. Not so much that it's going to cause any issues with your Parkinson's medicine, but what it does, it tends to kind of brighten up the frontal lobes a little bit, that area where you kind of connect with life, where you do things like what you do with interpersonal relationships, or you go to the grocery store, things that you plan. So it actually kind of enhances that effect. And so we use a fair amount of Wellbutrin with Parkinson's disease. There have been some new medicines that put Wellbutrin and, say, Lexapro, Prozac together in one pill. And those are pills like Cymbalta, you may have heard of that, Effexor, Prestige. So we think we might get a little extra bump from that. But the really good news in the treatment of depression comes from one of the newer medications, which called Trinitalics. That's probably the name you're going to hear most frequently. That's a branded name. Trinitalics has a kind of a unique effect, and I use a lot of Trinitalics. It works a little differently. It does a little bit like Lexapro, But then it does some other things in different parts of the brain, which makes it work a little bit faster. And the FDA has said, you know, this medicine actually enhances cognitive function, even if it has no effect on depression. One of the first ones to ever do that. It's been approved in Europe and in this country to enhance cognitive function. And when we talk about depression as we age, we want to do as much of that as we can. So Trinitalics is one of the new ones, one of the really good ones. Now, before we go any further, one of the things that we always look at as we see people with Parkinson's disease, as well as aging population, and now anybody that we might see with schizophrenia or bipolar that are on medications that we call anticholinergic. And that means these are medicines that tend to block the effects of a chemical called acetylcholine, which is important in memory. It's important in being alert, in being focused. So, and in Alzheimer's dementia, that's a chemical that goes down quickly. It's one of the ones that we lose early on in Alzheimer's disease. So any medicines that block what little we have as we get older, or say as it diminishes as we get older, or what little we have if we have Alzheimer's, we want to get rid of them. So you want to look at your medicines, let your doctor help you with your medicine and get rid of as much anticholinergic medicines as you can. Now, what are those? Things like Benadryl, things that make you sleepy, things like Vistaril, bladder medicines. The wrong kind of bladder medicines are very, very negative toward cognition. For example, bladder medicine, we have medicines like oxybutynin and ditrophan, not good. Very anticholinergic, but we have new ones called Myrbetriq and Gentessa. And if you're an older patient, you've got bladder issues, you should be on those two. Vesicare is also pretty good because it doesn't impact that acetylcholine. So as we get older, we start looking at these other medicines that might be causing us to have an impaired memory and having us to have a decrease in focus. One of the problems with aging is that we're just not quite as attentive as we were when we were younger. Things kind of get by us. We can kind of really just do one thing at a time when we might have been able to do a couple of things at a time. So any medications that you're on that may have a negative effect in that regard should be eliminated, and work with your nurse practitioner, your physician, and try to eliminate those. So again, the depression, we've got really good medicines now. It's so important to treat that early, because actually there's been some interesting stuff that shows if you treat depression early in any form of dementia, it tends to make the onset much later and gives you a better quality of life much later. Also, data recently says if you start a medicine that increases acetylcholine early, you have a better response as we go on. We talk about dementia because we see that in Parkinson's disease. It's fairly common as the age gets older and older. So there are some things we can do now we couldn't do 10 years ago. And so that's one of the things, is to get rid of those medicines that are working against that chemical, get started on the medications that enhance that effect. So things like the antidepressants, the really good ones like Trinitalics, eliminating the bladder medicines that have a negative impact. There's a medicine in Parkinson's disease that was used a lot called cogentin or benzotropine. We really want to avoid that. We don't see it used very much because it also has a fogging effect on the brain as time goes on. So what are some of the other things we see in a mental health situation in patients that have Parkinson's disease? Well, of course, sleep issues can be a big problem. There's a disorder called a REM sleep behavioral disturbance, where in the latter part of sleep, you can have just extreme fits and outbursts, and it makes the caregiver with you upset. There's yelling, screaming. There's this kind of behavioral, real negative kind of sleep issue. I had a patient present with that and had, actually it's one of the signs
Lewy body's dementia, but it can also occur in any kind of Parkinson dementia. But you know, here's the good news. We've got some new sleep medicines now. It can be very effective, very helpful. So we want to avoid the old sleep medicines like Ambien and Lunesta, those benzo-like drugs. Try to stay away from those. You don't really want to use the Benadryls. Trazodone's okay, up to 50 milligrams. Above that, it gets to be anticholinergic, works against that good chemical for memory. Probably don't, melatonin's good. We don't use enough melatonin in sleep issues. Here's the key with melatonin. Melatonin is sensitive to light and dark, okay? So normally, as it gets darker, our brain makes more melatonin, and as the sun rises, it comes back down and we wake up. So if we're using melatonin, we really want to key it to lightness and darkness. So if you take your melatonin, take it at 30, 45 minutes before you want to go to bed and kind of mimic a sunset. Let the lights get kind of dim. Take it with your 50 milligrams of trazodone or whatever else you're taking. And that's very helpful to create a better night's sleep. Melatonin shortens the time to sleep. That's when it really works. Leave your blinds open, you wake up with the sun. That begins to get that kind of natural pattern to go. So what are some of the other medications for sleep, the new ones? Well, there are two right now that are brand new. One's called Belsomra. The other one's called Dayvigo. Now, these are really different kind of medicines. So let's say this is the brain right here. And you've got all this brain activity going on while you're, you're awake and as you, this is the brain activity. And so as you're awake, it's kind of up in here, your brain's functioning, all the electrical impulses are going up in here. And as you're trying to go to sleep, you kind of want to get below that threshold. So where you're not active, and as you get below that, now you're asleep. You take some drugs like Ambien and those drugs, they just kind of put a fog on this, and it just, everything kind of slows down. But in the middle of the night, you wake up, you go above this threshold, you wake up and you're awake. And so then, you try to get back to sleep and you never can get back to sleep. So what this drug, it kind of sets this threshold up here so that if you try waking up in the middle of the night, you're still going to be asleep. And if you're trying to go to sleep at night, it's up here so you can get to sleep quicker. So it's a new mechanism. It's a different kind of mechanism, and it's safe to take. It's not habit forming. Had a lot of good responses with it. So you can take it like with the melatonin and with the trazodone. So if there are sleep issues, which are big as we get older, there are options that are safe to take with Parkinson's disease, and those are two of them. Anxiety, well, what's anxiety? Anxiety is when you're in the future. It's when you are worrying about what hasn't happened or what you may think will happen. Depression is when you're in the past. This is kind of generally. So if you find yourself depressed, you're usually focused on the past. If you're anxious, it's usually in the future. Different mechanisms, different ways to treat. But with anxiety, a lot of this has to do with anticipation. Therapy is helpful with that, as it is with depression. The medications that we sometimes use, probably the simplest, easiest is Buspar with an SSRI. Buspar is not good by itself, but with an SSRI, it's really good. Or like I said, that's an antidepressant like Clozapine. So you want it with an antidepressant. The other medicine that can be very effective is gabapentin or Neurontin. It's a common medicine that we have in medicine, used for the treatment of diabetic peripheral neuropathy. There's another improved form called Lyrica, but those can be very helpful and effective. And they're not nearly as anticholinergic as, say, a Xanax or a Clozapine or a Vistaril is. We want to try to avoid those as much as possible. So those are issues that can be very effective in the treatment of anxiety. Before we move on to psychosis, let's talk just a little bit about a treatment for depression that goes beyond medication. Very effective a treatment to approved by the Food and Drug Administration, the FDA. It's called transcranial magnetic stimulation. And what is that really? Well, it's a way that we can take a machine that can produce these electromagnetic waves. We put a helmet on a patient, and we can look at where these circuits are, the depression circuits, which are deep here, and the anxiety circuits, which are here. And the two treatments that are, well, three treatments now approved with this helmet has been major depression, obsessive compulsive disorder, and smoking. It's called transcranial magnetic stimulation, and you focus these electromagnetic rays on top of this area to reactivate it, so to speak, to get it working again, to start making the chemical, particularly when the medicines haven't been able to do that. I purchased a machine here, and I have it in one of my offices at Rolling Hills. About a year, let's see, almost a year. Okay, oh yeah, about a year now. And we've probably done maybe 100 patients, an incredibly good apparatus that can be very effective. It's a treatment that takes about 25 minutes a day, goes over a 36-day period, and it's covered by insurance. But my point is, it's an option that is available not only here. We have a kind of a unique machine. It's made by scientists over in Israel who developed really the technology. There's another machine. There are a couple in Oklahoma City. I know there are 2 or 3 in Norman, and obviously there are machines down in Dallas, but we found it to be very effective. I have patients at Rolling Hills who, when they come in depressed and have been on multiple medicines, I'll start their treatments there, and then they complete them as an outpatient, but an extremely effective way for the treatment of depression. There's another interesting medicine you may have heard about called Sprovato. It's a medication that is available that you can take it as an inhaled medication, and it works on ketamine, which is a chemical that can alter certain chemicals in the brain, and it's extremely effective for suicidal depression. It works quickly, generally used in those kinds of circumstances. We have a clinic that may be wanting to start the use of Sprovato here locally, so we'll see how that goes. So that's the treatment for depression, for anxiety, for sleep disorders, things that we need to be concerned about. The other medicines we take, such as bladder medications. Do you have any questions about any of that before we go on to psychosis? Everything's good?
Can you briefly also speak on impulse control?
Parkinson's? Yes, well, thank you for bringing that up. So, impulse control. Compulsions. What is that? That is doing something without an awareness of consequence, that urge to have to do it without the thought that this may be a problem if I do it. Impulsivity. It's a result of dopamine receptor dysfunction. And by dysfunction, when we say that dopamine can be too much or can be too little, and that receptor can get hypersensitized if it gets to be too much. In other words, you get so much dopamine floating around from your Cinemet, or your Ropenorol or Requip or Mirapax. You get so much floating around, or even now with Abilify or Piprazole is one of the issues, that it makes these receptors really hypersensitive, and it generates this impulsivity that can be expressed through gambling. Pathological gambling, hypersexuality, doing impulsive things, spending money that you wouldn't normally spend, just almost like a change in personality. I give you some examples. I had a young man that was on a medication like that. He was autistic and high functioning, and started taking things at church, and people kind of looked the other way. It wasn't really a big deal, but went to the library and took a computer and got the DA's attention. Of course, they were going to go press charges on this and create, a big issue for this young man. We made the connection and drew the connection between his use of the Abilify and the impulsive behaviors, changed the medication. He's been great since charges were dropped. In case of another man I saw maybe 10, 15 years ago, who had went through his life saving, was put on Maripax for restless leg syndrome, put on Maripax, and with 6 months, he went through several $100,000 of his life savings through a gambling addiction, just an impulse that was totally different from anything he had done in his life. Had another interesting young man, I say young man, 50s, to me that's a young man. He was in prison, I say in prison, in jail, in Oklahoma County Jail, and his people contacted us saying, this is a guy who had a good job. He worked with the church. He was a greeter and sometimes helped out in the church. And as time went on, he began to make people feel a little awkward around children. Nothing he actually did directly, but just some things that didn't seem right. And some accusations were made, and he was put in jail. This man had Parkinson's and had been started on, I think his was Maripax too, along with Cinemat. And this occurred over the course of about 6 to 7 months when this happened. Completely destroyed his family. They believed that, well, he's changed and done something bad. The DA in Oklahoma County felt the same way, was going to send him off to prison. Came over to our place and we evaluated him, made the connection that this was an impulse control disorder that occurred with this man, put him on other different medication, monitored the dopamine levels carefully, and he did fine. Finally was able to have the charges dismissed. I haven't heard a follow-up on whether his family ever took him back, but I know that he was still in the process of trying that happen. So bad things can occur with medications if you're not aware of the potential side effect. And you're right, that impulse discontrol can be a real issue. And if you see something change, something different on medication, you always need to be concerned about making that connection. Very good. Can you think of anything else we need to talk about before we go to psychosis?
Not off the top of my head. I think you hit it with the anxiety, depression. I know that sleeplessness is a big thing, and people, wonder, is it Parkinson's or is it the, just the old age and things like that, the medication and this and that, but.
Well, we always talk about create a good environment. You don't want lights. Lights wake you up. If you have trouble waking up, turn lights on, get lights on. That's what the natural thing is to do the brain. So you really don't want a lot of lights on. You like to have a little background noise. I keep a fan on. It bothers my wife, but I got that fan on. It just takes away some of that background noise. You have a TV on, that's not going to work. That's light. If you do have it on, keep the noise down, keep the lights as dim as you can. So there's that kind of sleep hygiene. You don't want to eat a lot of food 2 or 3 hours before you go to bed. You want to kind of minimize that piece to it. But other than that, probably melatonin, low-dose trazodone, probably the safest, along with using something like one of the newer medicines if you need to. The big issue with Parkinson's sleep disorders occurs, like I said earlier, part of that REM sleep dysfunction, where those agitated, aggressive kind of dreams that get acted out, middle of the night, early in the morning. That's the kind of thing that you will need to use some medication for, and that kind of fits into the psychosis part of this thing. So,
and we have lots of stories from folks of husbands waking up in the middle of the night, doing something or throwing the pillow or this or that. I think one thing with Parkinson's is you'll see there's a lot of things that you won't realize are linked to it. So,
yeah, exactly.
But yeah, I think that covers it. And then I think paranoia would be something, I guess, that would be more into what you're about to talk about next as well.
The psychosis, right. So let's talk about the psychosis. 50% of Parkinson's patients will have some experience with psychosis. If there is dementia associated with it, up to 75% will have some experience with psychosis. And what do we mean by that? Well, the hallucinations are a disturbance of perception of things with their auditory, their voice, if they're visual disturbance, a misperception of reality. Most Parkinsonian hallucinations are visual and not auditory. So it makes it a little different from schizophrenia, which are primarily auditory. Drug-induced hallucinations tend to be more visual things that occur with methamphetamines or LSD, for example. So what else can hallucination? Illusions, distortions of real things, like that chair beginning to morph into an animal, things that are real that don't seem to be real. What we call a presence, the sense of somebody's in the room and you look around and they're not there. Or there's, what we call something distant, where you're seeing something over here and you're looking around, or little lights are here in the periphery and you just can't seem to ever catch them. So those are a couple of the kinds of hallucinations we see. And then with Lewy bodies, there tends to be kind of the classical little animals, little children running around. And I can't tell you how many patients I've had with Lewy bodies that have, which is a kind of a spectrum of Parkinson's, but they're just totally convinced. And that's the thing about hallucinations. They are as real to the people that have them as I am talking to you right now. And what happens in the brain is that you go back here in the brain, what we call the visual cortex. And this is what processes what comes from our eyes, our visual cortex. What's happening, there's a disturbance, a disconnection, an abnormality in the visual cortex that makes the eye think it's seeing something. So, what's happening is this dysfunction is going back to the eye, and then it's coming back here again. So it's real to that person every bit as much as I am looking at you right now. That's why it's so hard to convince people it's not. I usually tell people, in a sense, your brain's playing tricks on you. It's the misperception that's a result of an injury up here or dysfunction up here. Same way with the voices. So it's real, and it's hard to talk people out of it. It's hard for people to admit they have it. Only 20% of patients will admit they have hallucinations or delusions, because they don't want you to think they're sick. And that's one of the problems. They don't want people to worry about them. They're worried themselves, but they're afraid to admit it. And when I think I know somebody's having hallucinations, I'll just automatically assume they are. And I said, well, now, how are they affecting you now, before they'll even tell me they have them? But then it's a little easier. Well, how did he know? But you can just tell a lot of times by the way someone talks about what's been going on. You hear things from a caregiver that'll say, well, I've seen them talking to somebody over here. I know that piece of information, so I don't have to ask them directly, are you having them? I'll just make that assumption. But it's hard to get people to talk about it. So those hallucinations, as real as they are, can be extremely disturbing. The other piece to this are the delusions. The delusions are fixed false beliefs. In other words, if 100 people agree on that this is a picture of Ada, or these are trees over here on this wall, a picture of trees, and one person says, no, they're elephants, who are we going to believe? That's a fixed false belief that this is something that's not. That's a delusion. They're hard to treat. I can tell you with my schizophrenic patients, I can treat hallucinations pretty quickly. I can treat disorganization of thought quickly. But the delusions of paranoia, that's a delusion. Paranoia is a delusion, the belief that someone is talking about me, or being mistrustful or suspicious of others. I frequently hear about the food in the home is poison, and I'm not going to eat it. It's poison, and I'm going to die from it if I eat it. Or been married for 60 years, and the pastor who's been a faithful part of your family for all that time, your wife's having an affair. You know, it's that those delusional thought processes that can be so difficult to treat. That's part of the psychosis. Interestingly enough, the newer medicine we have called Nuplazid can be very effective in this treatment. Now, let me tell you how they found out about how this medicine worked in Parkinson's disease. We don't have anything to treat psychosis, or we didn't have anything very effective to treat psychosis like this. You can't use the typical antipsychotics, the Risperidals, the Zyprexas, the Geodons, the Abilify, because it makes the Parkinson's disease worse. You're basically blocking more dopamine, and you want more dopamine, generally speaking, but you're blocking it when you use those antipsychotics. So you use those to treat the hallucinations, Parkinson's gets worse. There are a couple that we can use that are what we call softer on that dopamine receptor. The others are tighter, harder on it. And that one is Seroquel, the other is Clozapine. Seroquel, you've heard of it, it's used a lot. Anxiety, sleep. A nice medicine sometimes can be effective. There's one study that showed it was equally effective as Nuplazid, but most of us haven't seen that. The trouble with Seroquel, it's anticholinergic. It makes you sleepy, and most medicines that make you really sleepy tend to be that way, Benadryl. So it's going to have some effect on cognitive function, which we talked about earlier, we didn't really want to see. So Seroquel, okay, the first 150 milligrams of Seroquel dose is like Benadryl. They give you some effect. We don't need to use it. We don't really want to use it. The other medicine is called Clozapine. Clozapine is the mother lode of all antipsychotics. It's the best ever. You have to have blood test with it. It's the best for schizophrenia, but it does require some work. I'm probably one of the 2 or 3 largest prescribers of Clozapine in the country. I love the medicine. I use it for my schizophrenic patients, my bipolar patients. Tremendously good medicine, but in Parkinson's disease, it does a nice job on the psychosis, but you got to keep the doses really low. I'm talking like 12.5 milligrams, and my schizophrenic patients are on 600. So you got to keep it low. It does have some side effects, but a good medicine. So we didn't really have anything until they started looking at patients with LSD. And patients that have LSD have visual hallucinations. And they realize that what LSD does, it makes you produce a lot of serotonin. And there's so much serotonin that you got these hallucinations. So they started, well, you know, hallucinations kind of like Parkinson's. So they found out it was a serotonin problem in that part of the brain. So they developed the drug Nuplazid, which helped block those too many receptors, and it toned down the hallucinations and also toned down some of the delusions. So it's an effective medicine. It's one that doesn't make your Parkinson's worse. It has no effect on dopamine. It just works on serotonin. So it's considered to be the drug of choice for Parkinson's disease psychosis. And it's not difficult to get if you have that diagnosis. So a very effective drug, certainly the one we want to go to first. So I think pretty much that's, what else about psychosis can I tell you?
With Parkinson's disease, and how do you know if it's Parkinson's causing it, or
And something else.
Yeah, and how does Parkinson's disease bring on these types of delusions?
Well, I don't know that the hallucinations of Parkinson's disease are not much different than the hallucinations of vascular dementia, of patients that have Lewy bodies dementia, even Alzheimer's dementia. The drug is now, looks like it's going to get approved for that also. So I don't know necessarily that it's Parkinson's disease and that makes it, more of an issue.
With the rate being nearly 50%, is there
There's more likely a connection with the degeneration that occurs in that part of the brain. And as I said earlier, as you see more cognitive loss over time, you're going to see a greater incidence of the psychosis. So I'm not going to say that it's that unique, because I'll have some patients with vascular dementia that'll have similar kinds of hallucinations. I don't know that that's been completely worked out. But I think we are certainly aware of that in Parkinson's disease. And, with these treatments that we have now, it's certainly something you don't want to wait on. I think here's the thing about psychosis that we know from a lot of other disorders. You want to get it under control quickly. The more psychosis you have, the more negative effects that has on your brain function. The things that make you produce new brain cells, which you can as you get older, tend to be subdued if you're having ongoing psychosis. So I think there's a very strong impetus to encourage people to pick up on these symptoms and get them treated. I worked with a well-known psychiatrist with Clozapine and schizophrenia, and we did a trial, published the work with Nuplazid and Clozapine. He's very, very strong about letting people know any psychosis is not good. Good voices are not good. It means that there's activity going on that's going to cause continued degeneration. So the best message I can give you, if anybody has any kind of psychosis like we've described, get it treated. Encourage them to get help, because we've got, like I said, good treatment. Your brain will last longer. It's like treat your depression early. Get your anxiety toned down. Get a good night's sleep. Avoid medications that work against your Parkinson and against your brain function. Get your psychosis under control quickly, and it's a better quality of life. There's better quality that's going to come with it.
Two final questions, and then we can, if y'all have any questions, we can open it up. If you need treatment, where do you go? Do you recommend just going to your neurologist, or asking them where to go? And then also any advice for caregivers? You mentioned it's hard when you deal with these situations, to maybe convince someone otherwise, but any advice for caregivers as well dealing with this?
Well, I think with caregivers, I think you encourage resolution. You encourage to speak out about these mental health symptoms, again, because of the impact not only it has on the individual that has the symptom, but the people that are taking care of them. It's difficult to watch somebody suffer through a severe depression when you know they can be helped, or have severe anxiety. And there's some of that stigma, I think, that goes back generations. I don't think it's as much with younger people as it is with older people. I still find older people that don't particularly want to talk about it, or they don't want to talk about Aunt Sue that had a problem, but it's some of the stigma we need to get rid of.
And I think with Parkinson's disease, roughly half the people that'll be at our conference are going to deal with this. It's something that we see people don't speak up about a lot, but so many people experience it, and I think it's a lot more common, especially in the Parkinson's world, than we realize. And so I think obviously movement disorder specialists that folks see, they're going to know about Nuplazid and things like that, but if that's a medication that you need, kind of what's the path to go?
Well, let's put it this way. I've worked with a lot of neurologists. They don't particularly enjoy dealing with psychiatric issues. And so I would say, and the good ones will refer you quickly. I will say that for them. But I think this is why Parkinson's disease is called a neuropsychiatric disorder. In other words, it has a handle in the motor function, comes from the neuro, and then the psychiatric, the mental piece. And so, that's two different areas. And I'm going to tell you, the medicines in neurology are so many and so unique. It's hard for a psychiatrist to know all of them and the nuances. I can pick them out and have a pretty general sense of it, but I don't know the nuances near like they do. Same way in psychiatry. You know, I've got great neurologists. We go back and forth. He leaves my meds alone and I leave his meds alone. So they're good working relationships, but you really need to get that combination going. And I think most neurologists will try to encourage you to get with a psychiatrist to help you. But again, this is where you want to make sure that you're careful with your medications, that, you know, get your pharmacist involved. I like to see pharmacists get involved and help pin out some of these anticholinergic medicines that they can point out that you can bring to your doctor and say, do they really need that bladder medicine? Can we maybe use this medicine? So it's a teamwork. Even your pharmacists need to be involved.
Perfect. Well, I'm going to go ahead and stop the recording so we can get some question and answer. And if anybody on the question and answer has a question, feel free to type it in and we'll let the doctor know. So go ahead and stop this recording.